and we're excited to get things started. So we appreciate everyone's time tonight. We're starting as close as we can to 5 and to conclude at 6:30. Please note if you are listening, if you can mute if you're not talking, that will help us with the background noise. The team here will also do some muting of individuals on the phone, but we can't control those on the video. Melanie, can you provide us with a little bit of logistics for the meeting before we turn it over into the discussion?
Sure. Thank you, David. To start off, I want to say if anyone is having technical issues, please contact Anena or I, and we will try to resolve those issues for you. I want to remind everyone this meeting is being recorded. So the committee members in general will be unmuted. Staff may mute you if there's background noise. Anyone can unmute themselves. Again, I said this a little bit earlier, but anyone can unmute themselves by using, there's a small button that looks like a microphone. And if you push it once, it turns red and you're muted. If you push it again, it should turn white and you're unmuted, okay? Please remain on mute when you're not speaking to reduce the background noise. So you can use the chat function. It does send notes to all attendees. In this technology, you can't send a chat message to specific attendees. So we're going to try a process for identifying people who'd like to speak by taking a piece of paper, folding it in half, and holding it up. For those of you who come to our meetings, we use tent cards and put them up. So we thought this might work. So if you can just fold a piece of paper and hold it up, and then the facilitator, who's going to be David, will call on you. So we'll try that for this meeting and see if that works. So those are the housekeeping items. I'm sorry, David, go ahead.
Just to note that Stacia is not going to be able to hold that paper up. So Stacia, we'll look to you to just sort of jump in when you want to make a comment. And I don't know if Dr. Berenson left or if he's still on, but I don't see him. So if you find that we've sort of glossed over you and you're waving paper, please just chime in. We think that the note card.
I'm here.
Wonderful. We think that will give us a way, the flyer will give us a way to have more orderly conversation, but we'll try it and see how it works in this virtual environment. Melanie, anything else?
I just want to let everyone know Anena is working with Patrick Dooley to get connected. He's having trouble logging into the meeting. So just so you know, he's trying to right now.
Okay. All right, good. So with that,
and this is Stacia. I'm going to reboot my machine and see if I can get past our firewall. So I'll keep working at it as well.
Wonderful. And in the email earlier today was the contact information for our team, Anani, and who else was on that? Melanie, yourself?
I'm sorry, myself and Alana. But it's better to contact me or Anena because Alana will be doing notes into the spreadsheet.
Okay. Wonderful. So with that, following the agenda that everyone has, I would ask Dr. Haff if he could talk a little bit about what brought us to this discussion today.
Yeah, thank you, David. I'd like to thank all the council members and subcommittee members who are joining us and others who are joining us tonight for what I hope is an important and meaningful discussion about payment and healthcare delivery systems for this program, for Maryland, and hopefully for models that we can use going forward that help us to develop sustainable and models for supporting healthcare provision that are resilient throughout all sorts of circumstances in the future. So I mean, we've always contemplated having an opportunity to tweak, as if you were, the system as we went ahead, while still maintaining the overall integrity of this program, so we can be able to adequately analyze the effects. But the events of the last 4 or 5 or 6 months have really made that even more important. So we're moving ahead now even more quickly than we anticipated in looking to design an alternative payment system, a track 3, as an option in the MDPCP, and doing it with abundant input so that we make sure that that it's not something that is designed without a variety of thoughtful people anticipating how it might affect both this program and how it might affect others in future payment systems. So we do know a couple of things about our particular process that are relevant here. One of them is that we're working at, obviously, is a model and in collaboration with CMMI. It's a model that engages both the state and CMMI in this process. But we know that for clearance purposes, based on what we've seen and experienced in the past and what we've been clearly told from our colleagues at CMMI, for clearance purposes, whatever new models we might put into place should have a clear resemblance and familiarity to things that have already been cleared within CMMI in order to expedite the process. And knowing that there are many levels of clearance that need to go in place for any payment change, and that in best cases, even with simple changes that may take a year or more to expedite a system change. We've been strongly encouraged to do whatever design features we are going to submit for an optional track 3 to make it look very familiar to CMMI, as in mirroring one of the existing already cleared models. And the strong inclination was, and from them was we could use the most recent model, that is primary care first. It would even further help facilitate the process. So I think that's good fundamental guidance. We also know that we've been told clearly from all levels of leadership at CMS and CMMI that they're looking to be able to reduce any administrative burdens, to make all systems emphasize patients over paperwork and simplify designs as to the extent possible. So those are the kind of the two overarching kinds of instructions: make it look like it's familiar and make it simple at the same time. We also know that as we move forward with this is a work group that will be creating some documents that will then be referred to CMS and CMMI for their ongoing evaluation and put through their process. Ultimately, that's a process that takes a year or more or less, a little less of editing back and forth and clearances before it's finalized. So we have work to do now to get that started, knowing that there's a long process ahead. We've pledged to our colleagues at CMMI by the end of September that we would have something that was looking like a credible variant of primary care first for them to further evaluate and provide feedback. We will, as we iterate this process over the next month or two, we'll also give them opportunities to comment along the way, so that we make sure that we're directionally correct in the things that we're suggesting. I really rely heavily on all of you to and your wisdom, your experience, your actual boots on the ground experience with payments, and your guidance to make this a good product.
And Dr. Pham, question for Dr. Haft.
Dr.
Yes.
Haft, I'm so sorry to break your rhythm, but I realized in
No
retrospect,
problem. I'm done.
I realized in retrospect, having gone through the spreadsheet of design parameters, that I didn't ask a really fundamental question here, which is we can do our best, and it wouldn't be hard, I don't think, to pick parameters that look familiar to CMS. But what I do not see them calling out for, or any sort of guidance from them about how we should handle the COVID-related methodologic issues. Those are significant. They touch on pricing, they touch on attribution, they touch on the quality metrics, and we can wait and just say we will just mirror whatever CMS decides for its own primary care programs, but I think that should be a deliberate decision. And having seen some of their decision making around their ACO programs, I'm just a little concerned. I would encourage Marilyn to be explicit in laying out for the agency what your expectations and assumptions are with regard to COVID-related issues in this design effort.
Yes, I thank you very much. It's an excellent comment, and I think that should be considered here. And part of the consideration may be that as we move more toward a capitated system that provides sufficient funding for ongoing operations under any circumstance, that makes practices more resilient to the kinds of things that we've experienced in COVID-19. So that would be that's a fundamental issue. But Dr. Fallman, also there's companion work that's going on and that is not directly related to this, but indirectly related to this. And the state is, or the Department of Health specifically, will be doing simultaneously an annual report and making recommendations within that annual report. And the recommendations will also be presented to the advisory council for their consensus, and they will, I'm certain, we're already started drafting those. Those will include those kinds of recommendations specifically to the points that you're making here in terms of immediately COVID-related issues. So I think we'll look at both of those things, but I think it's great. As much as your point is well taken, much as we can incorporate things that will make the design resilient, whether it's COVID or whatever the next pandemic or interruption in the usual delivery of care is, we should take this advantage to incorporate those things. So thank you for that great comment.
So Dr. Riemann, a response for Dr. Pham?
Yeah, that's a really good point, and I appreciate you bringing it up also. I think what I'd suggest we go through our template and our questions, we keep that in mind, especially when we start talking about population measurements and how we do that. It's been very difficult with COVID, and I think that's a real good point. And so I would suggest as we go along on each of these topics, if anybody has any thoughts along how that ties into COVID, that we bring it up then and we add it to our report. I think it's a really good point.
Okay, wonderful. Dr. Haft, any additional remarks to make on the as it relates to the CMMI request?
No, I think I touched on all the important points, and maybe the other, probably the most important point is there is no specific warranting by CMMI that any work that comes from this work product that we produce will be accepted in all or in part. So we at this point are doing work with the anticipation that it'll be well accepted, but again, that's not a guarantee.
Okay, understood. So we're going to, Dr. Riemann, with your permission, we'll move into the actual discussion, and I'll take us through the logistics if there's nothing else you need to comment on. Okay, so this may be a little clunky as we get started.
Before we begin, I want to remind everyone that this is an open meeting, and
yes,
we did not, I don't think we brought it to everyone's attention that others may be on the line. They have been asked not to speak, but they are in listen mode. In a virtual meeting, you don't always realize that. So cursing and swearing should be kept to a minimum.
Thank you. Dr. Berenson, comment, please.
Is CMMI on the line? Are they listening in? Do we think? No.
So, Dr. Haft, we didn't explicitly notify them about the event, did we? I don't recall.
No.
No.
Okay. Okay. So, as I mentioned, we'll try to get in a rhythm. So, bear with us as we get started. This is a little new for all of us. So, Alana on our team here is going to bring up the worksheet in which everyone is seeing, and we'll use that as the tool to work through. So it'll look like this, and you should be able to, if you've tiled all of the participants you should be able to see them on to your right. And how the approach we plan to use is I will note the design element, a couple of items as it relates to that design element. And then what you'll see in yellow is the recommendation in which you all responded to. The column just to the right of that, where it reads consensus, is where the feedback was harmonized to the best extent possible. It was really great feedback from the advisory council committee. And then Dr. Reedman will lead the discussion on the consensus items to try to create as close as we can to a center balance. We're not expecting this to be where it's sort of a circle in a hole where everyone agrees and it's a unanimous discussion, because as Dr. Half mentioned, these are ideas and concepts. If we can get everyone to say, yeah, we think this is doable, that's probably as best, and that's probably as close to perfect as we can get today. We have about 16 items in this table, give or take, and we're not expecting to get to all of them tonight. If we can get through somewhere in the neighborhood of half, we will have done well as we anticipate the meeting this time again next week. So with that, let me start. The first design element we're going to talk about is going to be total monthly payments. And I think, Alana, you have to scroll down just a little bit. And we're going to talk about total monthly payments. As it indicates, practices are paid to deliver advanced primary care inside and outside the office. There are a couple ways they're paid. They get paid by TPCP, the total primary care payment, two elements: the lump sum professional population-based payment and the flat rate payment, which is $40.82. And what we have in terms of the recommendation on the table for discussion is essentially preserve the MDPCP payment structure that pays by individuals attributed to beneficiary's HCC score. And the group tended to agree with the flat rate of yes, and we would eliminate the adjustments. So Dr. Reedman, can you take us through the consensus elements?
Sure. Thanks, David. And also welcome to everybody. It's been a tough couple of, actually more than a couple of months since our last meeting. So I know everybody's been in the same situation we have, and I certainly appreciate everybody taking the time to respond back to the survey and to participate in this subcommittee. And we're going to try to make this as efficient as possible. So I'm going to pause after each one of these items and ask for feedback, and we'll go from there. So the first consensus was that the flat rate payment should be encounter-based. One member recommended decreasing the flat rate as the population-based payment goes up, and we'll talk about the population-based payment in a minute. But there was that recommendation by one of the committee members. So I would ask, one, if everyone agrees, or in fact, to make this easier, if you don't agree, please chime in. We'll give you a minute to wave your white flag or to interrupt if you're on the phone, and on both of those points.
Dr. Berenson, you look like you have a question.
Yeah, no, I would just make the point that with the blend of fee schedule and capitation, it's not as big an issue, but there is a real tendency to refer to specialists if you're not getting paid something reasonable for a visit. And so I'd be reluctant to go down. I actually had suggested the possibility of having 2 visit levels, but I sure wouldn't reduce it, because as it is, as one of the points I made was that referral rates are skyrocketing now. And I think we would want to keep 4082 or whatever it was as no lower than, and maybe consider even escalating it with inflation or something like that. How was that determined, by the way? Do we know where that number came from?
On the which specific number, Dr. Berenson?
The per visit rate, the $40.
On the flat rate of 4082. I do not. Does anyone else on the call on the? No, for sure.
It was Bob. I think it was a a very back of the envelope analysis by CMS, trying to get as close to historical average revenue as possible.
Yeah, okay. I mean, sort of at the back of the envelope, since what we're doing, that's probably reasonable as sort of the marginal cost of seeing another patient in the office, and it seems sort of in the ballpark. But my basic point here, I have no problems with a single rate. I just want to bring it down any further. I think that's moving us to full capitation. And I don't think we're ready to go do that. So I would maintain a visit rate, and I would keep it at a reasonable amount such as this one.
Got it. Okay, Dr. Pham.
I will second Bob's motion. I probably am not as confident as he is in the opinion, but I will second that.
Right. Any other comments around the particular item of flat rate payment should be encounter-based? Okay. Dr. Friedman.
So I will also agree with Bob's recommendation, especially about the increased fee, and certainly not ignoring that. Melanie, are any of the other committee members that I can't see on the phone? Did Patrick get in, and did fill in?
Patrick is in. He was having some trouble unmuting. Let me look and see if he is. Patrick, are you able to hear us and unmute? He's definitely on.
Yes, I can hear you all, and I just unmuted myself. Can you hear me?
Yes.
We can hear you.
Great, thanks.
Is Stacia's still on?
Stacia's here.
Yeah, I sure am. I'm still
see
trying. I'm still trying to think through this a little bit about what's being recommended here. So, could you just recap it?
So what we're talking about is the monthly payments right now, and that there's a flat rate. And the first consensus was that flat rate was a reasonable starting point. There were some suggestions about maybe decreasing that as the population-based payment goes up. And the consensus we just kind of confirmed was that with at least 3 of us, was that we should probably keep that as a minimum. And if anything, go up from there, and certainly at least have a cost of living raise on that every year also. That was kind of the consensus for the first item.
Okay, so we're talking about an encounter rate incremental to a population-based payment. I think that's the piece I was trying to track, is if we're talking about both an encounter rate on a per visit or per click and a PMPM, that's a population-based payment.
Yes.
Yeah.
Oh, Dr. Barrett.
Well, I mean, is it per visit or per click? I mean, is it per touch or per visit? I think I saw some suggestions that any kind of an interaction with a patient would generate the rate, and I think it should be a per visit rate.
So it does say per visit.
Yeah.
Dr. Barr, comments?
I was going to go there too, Bob. I think a couple of us made the recommendation to change the language from per visit to per encounter. And it goes back to some of the comments that Mike made in terms of the new world where telehealth and others. But I also added with appropriate documentation. So it's not just any encounter, it's one that would support. So what we would normally call a visit in the bricks and mortar world. That was my bias. That's what I kind of meant by encounter.
I think it's a good point, and it goes back to Dr. Phamb's comment about the COVID, that, in this modern world with more telemedicine visits, more video visits and all, I wouldn't mind certainly as a practitioner, that's taken a much more significant amount of my time. And I wouldn't mind it being, whether it's 2 fees, one for non-office visit encounters versus office visit encounters, but I think that's a reasonable thought to make it per encounter, or at least a fee per encounter versus just for office visits.
And that works. And Patrick, giving you a chance, a bite at this conversation, any remarks here, or are you comfortable with what we have?
Yes, I think my feedback in the document reflected some of the conversation right now, that to me a visit wasn't a visit just because of some of the reasons that have been highlighted, and that you may want to differentiate it some without over complicating things, to recognize some of the comments that I think others have made, that a face-to-face encounter is not quite the same as another visit, and by kind of equalizing all of it, while I understand the value of simplicity, it may kind of miss the mark on what you're trying to achieve.
So if we change on the consensus column where it says flat rate payment should be encounter-based and change that to be flat rate payment should be visit-based, that would address the concerns of the group on this particular line item.
Yeah.
Dr. Barr. I think
I have some concern that this is going to make it through CMS. So is what we're trying to do get aligned here before we try to figure out if we think that's going to make it through CMS? Because I'm not sure this will. I'm not sure it's consistent with where they're trying to go. And so, you know, we did, to the extent it's helpful, we did the whole aligned primary payer application on the, you know, in our other areas. And I'm just concerned about, we can make a recommendation that we all agree on, but if it doesn't actually result in CMS blessing us moving forward, I feel like we're going to have some challenges there, and we may want to consider that.
so. I'll call on Dr. Haft if he could make a couple remarks here, but just it was discussed before you entered, I believe, that what we're doing is making recommendations, and there'll be opportunities by CMMI to provide feedback on that. But I think Dr. Haft will reiterate, as close as we can stay to the primary care model, the more likelihood the recommendations will go through parents. Dr. Haft, can you weigh in to keep me honest here?
Yeah, no, I think that's exactly right. And it's, I think the directions that we have are that, you know, it should look substantially, the outline, the direction should look substantially like primary care first. And I think I believe if we adhere to the two payment strategy and try and simplify that and make it easier to understand, I think that will still be adherent. And I'm, you know, in terms of other directions that CMMI is or isn't going, I think you know, I think we were going in a direction before COVID that everyone was going, which has now shifted 180 degrees. So I would not make any assumptions on what future direction. We have elections and pandemics to get through before we assume what other people are thinking.
So would the group be open to some sort of, you know, I can agree and be in consensus with that as an initial year proposal. And I'm wondering how folks feel about us proposing a phase over time where the fee schedule decreases over time as the population base payment increases over time.
So it's a graduated approach is what I think you're suggesting. Is that right, Stacia?
Something, I'm just using this as a hypothetical, something like we start at, you know, a 70-30 blend, then we move to 75-25, then 80-20, then 100 and 0. But that over time we demonstrate as the capability to manage that gets more effective, that we get on a trajectory that's heading towards more full population-based payments, i.e. capitation, that we may be best served to propose a graduated over time than something that's going to be constant through a 5-year period.
Okay. Dr. Barr, I think you were going to make a comment, and then Dr. Barringer.
Yeah, thank you. On an earlier point, I would not support changing what we have proposed in terms of encounter back to visit-based. I would suggest defining it further, whether you decide to treat them differently in the payment in terms of a virtual visit versus a bricks and mortar. You know, I think it's pretty clear from what we've heard from CMS at least that telemedicine is not going away. They may figure out how to pay for it going forward. So I think we should anticipate that, call it an encounter, define it further if we choose to, but not go just to visit-based, which is, at least in the current parlance, means physical encounters.
Yeah, that's a very good point. I think it accomplishes what the group is saying is, you know, it should be expanded, but the way to do it is stay with the current nomenclature, but define it differently. Dr. Berenson, did you have a comment?
Yeah, I did. On that one, you could call it an encounter, you could call it a visit or visit equivalent. But either way, I got the point. But I think moving towards 100% over 5 years or something is a very different payment model than a permanent blend. I think it's got some virtues, but I think one would have to have lots more robust quality metrics to detect stinting. You'd have to have much stronger risk adjustment of the capitation amount. And I think this sounds fairly fundamental, whether we think that we are establishing the right, with some tinkering over the years, the right blend between fee schedule and capitation versus the goal of getting to full capitation. It might well be that there's a subset of physicians who could manage capitation and that we would have some confidence that they could. But having practiced under full primary care capitation, I think it's a very different animal than what we're talking about here.
Understood.
But can I just ask a question though? Because I'm trying to think through this. I think one of the challenges that I've heard from folks is, quite honestly, it shouldn't matter if it's visit face-to-face, visit telemedicine, telephone call, email, chat, carrier pigeon, or Morse code. It should be whatever's going to produce the best outcome for the population that I'm serving and responsible for. And I think if what we're trying to get to is getting away from the I'm going to call it an artificial construct, but only because I think it constrains people in ways that are unintended, right? If you're going to get away from having to account for and document every single click, if you will, encounter, if you will, into let's manage patients in the most effective way, and frankly, and consistently with their wishes, that we got to get away from a visit-based architecture. And that's the piece I'm trying to think through here. I agree, in a year one, in a year two, that I would agree that providers are probably not in the space to manage that. I think we're in a really different environment today than we were in the early days of capitated environments, and in the early days without the right data and analytics to support it, without some of the capabilities that frankly we have now. And I just wonder if we're trying to hamstring ourselves to an old, if you will, visit-based payment mechanism instead of moving meaningfully towards population-based payment, that we're not solving some of the other things that I hear docs care about.
So let me invite Dr. Pham before you weigh in. I think we have an operational challenge. Melanie, is there a concern we need to address?
Well, Dr. Weidman was trying to make a comment that he put into the chat box, and so he's having audio issues. I just wanted to be sure that he's able to be heard. It is related to this issue. So, David, do you want me to read it? Or
yes, please.
Okay. So his comment, Dr. Weidman, are you able to talk now? I'm sorry, Weidner, are you able to speak? Yeah, I think he can't. Anyway, so he said that I would consider specifying flat rate per EM encounter, not including procedures. So basically, anything for an EM encounter would go in that flat rate. So I don't know how other people feel about that, but that was Dr. Weidner's input. Thank you.
So thank you, Melanie. Dr. Pham, Dr. Weidner will work behind the scenes to try to resolve your technical challenge. I think Anani's there to assist. But thank you for that feedback. Dr. Pham.
Yeah, so I think I'm landing somewhere between the two polar opinions. And the reason is because there's a lot of literature to suggest that physicians do best under a blended approach because they retain some productivity incentive. Now, if we think that it's able to segregate that from the issue of how much documentation they have to do, I think there are ways to segregate that. I want to point out too that one place where the agency has often run into trouble in the past, and where I know they have some sensitivity, is that in a full capitation context, such as in MA, they get no data, or they get very junky data. They have spent a couple of decades now trying to catch up with the poor quality of the encounter data that they get from MA. There's a reason why we instead of using the MA mechanism to pay Pioneer ACOs, we insisted on their submitting claims and then the agency zeroing out those claims. That was because the providers then, relied on us to do risk adjustment. And we had the data with which to do risk adjustment. That can be segregable, I think, from documentation requirements to support those billing codes. So I know it feels like a minor pedantic concern, but it has real dollar implications down the line. I also want to, honor the fact that there is literature suggesting that a blended payment approach generally will keep things in balance. It's, if you get the ratios right, you've removed the marginal incentive to do another visit just for the sake of doing another visit.
Mhm.
But you still have some productivity incentive in there. Having said that, can I imagine a world where we get to full cap for primary care in the future? Yes, I can, especially as an option. I think as a one size fits all, and I realize we're not saying that because this is just one track we're talking about. But I think that we don't have a lot of data yet to see how this plays out in the Medicare context. And it couldn't hurt to see how it plays out in the data before committing to that for this track. That's all.
Thank you, Dr. Pham. Dr. Berenson, did you have a comment? And then I would.
Just very briefly, I mean, I think the arguments on both sides are pretty good. Do we have to sort of make this decision now? We're developing the track 3 right now, and I think, can't we be agnostic about where we want to go in 5 years?
So I think you read my mind. I was going to suggest to Dr. Reedman something similar to that. Dr. Reedman.
No, I think that's exactly where I was going with this. I think there's 2 points here. First of all, from a logistics standpoint and a time standpoint, these are great conversations. I was joking with someone the other day with these video conferences. The nice part is I'm the smartest guy in the room, but I'm not the smartest guy on this call. And there's some very smart people and great comments here. And I see both sides of it. I think that the point of this is a track 3 to conversation is what maybe Stacia's getting at would be more along the lines of the track 4 conversation. The other thing is, I think that we don't have to make a decision tonight either. What I think we would do, we've got 3 meetings set up for this, 3 subcommittee meetings. I would hope that we could get through at least most of this through the first 2 meetings, come up with a consensus, and maybe spend some time on these more important points or these more controversial points once everybody's had a chance to digest it. And maybe our 3rd meeting is where we would do it. So unless anybody else has any comments for this first item, I'd suggest we move on to the second one, and we can.
I actually just have a clarifying position.
Sure.
I wasn't in any way trying to have a polar opposite position. I was really trying to put some of the questions and concerns on the table so that we could consider them as a group. It would be helpful to understand when we're proposing a track 3, though, I would presume that is a multi-year track 3 that's not intended to be a single year solution. And I thought all of the tracks have been proposed in tranches of 5. Is that incorrect?
Dr. Haft, do you want to confirm? I believe that is correct. Dr. Haft, I saw 5 years. Is that your thinking?
So it's not a question that we've addressed yet. So we have the program continues through, at a minimum, through 2026. So this would be a 2021 or 22 start. So it would be 4 or 5 years. But what's still in the balance is that sometime in 22 or 23, there'll be a decision made at CMS and CMMI regarding continuing the program past 2026. So I think those are great points, and it's open question yet. So I would say it would probably, if approved, it would have a minimum of a 3-year span and maximum of would move into something between 5 years and perpetuity.
Yeah,
And then, Dr. Haft, is it your perspective that this would be an optional track? So nobody was forced to go into track 3, right? This is intended to be a more mature track for practices who are further along the continuum, right?
Yeah, and we'll get to it a little bit later in the discussion. But as we conceive of it initially, it's you would have to be at least a track 2 or track 2 qualified practice to be able to, and have had that experience before you moved into track 3. So it would be a succession. There's some nuance in that, and if you start out as fully fledged entrant into the program, looking like a track 2 had already taken capitation, et cetera, maybe that would be a qualifier, but it would be a succession. And it would be optional. So, clearly that there are some practices that we want to retain in the program that are small, medium-sized practices that may not have the capability of even this kind of maturity in terms of payments.
So does that change the perspectives of anybody else in the room about if this isn't a mandatory track, it's a voluntary track, it's intended to be for practices who have matured their capability set, and it's supposed to be multi-year? Does that change people's thinking about the idea of a phasing in schedule of ramping down encounter-based payment and ramping up population-based payment?
Dr. Riedman? And you're muted, sir.
I would say that the original plan of keeping that base rate for the track 3, there's also a basic cost of running your business. And to run a business, we found that, having some consistency and knowing what's happening next year and the year after is been very helpful. We've had some other payment programs where it's difficult to run a business when you've got very huge swings in your income from year to year based on the population part. So I think the basic fee we're talking about, I think that's a reasonable option, keeping that flat rate. And then as the population payment goes up, base goes up, I think that's where the incentive comes from. But I like the idea of keeping this flat rate at the 40 and with the potential cost of living raise, and then keeping the variation in the population-based part of it. At least for track 3, and maybe track 4 is different.
And Dr. Riedman, I think Dr. Berenson was going to make a comment, and then I would propose that we move on.
Mm-hmm.
And Dr. Berenson, you're muted.
So, Dr. Riedman, I'm sorry, but this is my only chance to raise my HCC objection. So we can't move on quite.
No, we're not going to, because I have the same objections.
I wrote a long essay. HCC goes along with total cost of care. We're not holding these practices to total cost of care. We want to do risk adjustment for performance risk, not for insurance risk. And it seems, so this may be a fundamental problem with CMMI because they've adopted HCC for lots of things. I was actually at CMS when we developed it. I was supervising the development of it for health plans who are accountable for total cost of care. It wasn't developed for primary care docs. And there are alternatives, which I cited in that 6-pager that I gave out. And so the question I have is, can't we come up with something much more reasonable, much less? And the final point I'd make here is that primary care docs represent 2.5% of total Medicare spending. We really think we want to sort of use a metric for total cost of care for docs who spend 2.5% of the total and hold them accountable for total. I just think it's inappropriate. I completely agree with the idea that we want to have utilization metrics that are associated with spending, but we're not doing total cost of care, so we don't want to use a risk adjuster for total cost of care. And with that, I'll stop.
Dr. Berenson, I think we probably will find many people disagreeing to a great extent, but I think the question would be, that I would have would be the compatibility with kind of this prime directive that it needs to look something like what a current program is, and establishing a new risk tier may be too much for CMS to accept. That would be my only comment.
Well, I guess my response would be it has been developed by Arlene Ash for a primary care capitation demonstration in Albany, and it would obviously we would need to re-look at it. That was 10 years ago. This isn't, I mean, and in fact, there's experts, Jerry Weiner at Hopkins and others are risk adjustment experts. So we could start with HCC, but with the view that perhaps we would modify it in year 2 or something like that if we need to get this going. But it's not, it's the wrong risk adjustment.
I agree.
I would suggest that, and I don't know, again, I'm not the smartest person in this committee, and y'all understand more about the CMMI and how it works and all, but my suggestion would be that from the standpoint of the HCC, that kind of like what Bob just said, was that, you know, maybe we use that initially, but certainly our recommendation from this committee could be that we don't think that's the appropriate long-term measure that we should be using, and there are other alternatives that we would help to develop, or we would make suggestions to them, but at least the committee could suggest that long-term that's not the best option to use. Whether CMMI is going to change it or not, but we certainly can make the recommendation that we don't think that's the best option. It also puts a lot of burden on the primary care physicians to, our group as an example, changed our operating system from a small one we used for about 15 years to the Epic system. And our HCC scores went up significantly when that happened, mainly because it made it much, much easier to pick those HCC scores and find those scores, spend less time doing it. So what happens with the average primary care physician, especially the smaller groups, is you end up with someone who it's very difficult to get those HCC scores in, which really significantly impacts your compensation. So I think there's a couple of problems with it, but maybe we make the recommendation it's not the best option. I'm sorry, Melanie, you had an input from somebody?
Yeah, I'm sorry, it's from Dr. Wiedner. But David, did you want to did you want to say something and then I'll clarify?
No, go ahead.
Okay, so this is going back to his comment that he had made. He said, if we propose payments, should be encounter-based. Those encounters should be E&M encounters, not include procedures, perhaps not wellness visits and other non-E&M encounters. And he put that in the chat for anybody who's interested in reading that.
Yeah, I think Alana has captured that. And Ben, were you going to make a point? Oh. Okay, and you're muted. Sorry, Ben.
I withdraw my hand.
Oh, okay, good enough. Dr. Riedman, okay to continue onward?
Yeah, so I would going through those first 4 items, I think we kind of covered those for the most part. And I agree with the HCC was on there. And so unless there's other comments about those first 4, I think we had covered that pretty much in our conversation, unless someone disagrees or has another point there.
And Dr. Riedman, would you summarize? Would the summary to be to say that there's general consensus, but we also want to have some discussion around including in the recommendations the feedback that's been noted by the committee here?
Mm-hmm. Yes. Yes.
Okay. Then moving on to the next one, Alana, can you scroll us down a little bit to performance-based adjustments? And in this category, there are 2 types. Just as a reminder, I'm sure you all don't need much of that, but I'll just touch on it real quick. There's a regional performance bonus, and the second one is the continuous improvement bonus. During the practice's first year of participation, the performance is based on acute hospital utilization. And in performance year 2 and subsequent years, it's based on the total primary care payment. And there's also a quality gateway that's included in here, just as a reminder. With that in mind, the recommendations, just to highlight some key elements, was simplify and target PQIs, hospital and ED reductions. The next one was largely greatly simplify the understanding for practice and reduction in administrative overhead. We've heard this a lot from physicians on this advisory committee. Eliminate the AHU and focus on ED and hospital PQIs. Eliminate threats to sustainable infrastructure, which to Dr. Pham's point about the pandemic, not work. The regional bonus still ensure how this works. And the continuous improvement bonus eliminate in order to simplify. And with that, Dr. Riedman, the consensus.
Okay. So the consensus, again, you can certainly review everyone's comments, and we'll talk about some more tonight. But the elimination of the AHU was sort of a consensus statement that was kind of agreed to. focusing on the ED and the PQI, the patient quality indicators, was important. I think how you measure that PQI is another difficult thing, and we'll get into that a little bit, I think. Include relative and improved benchmarks. Include measures based on actual total cost of care. Again, if I go through these, if someone has questions or input, just raise your white flag again. Consider the SDOH adjustment. Practices that generate total cost of care savings are eligible for the 50%, provided they meet or exceed the quality gateway, and recommend shared savings be paid in 2 quarters later, in addition to the PBIT, the CPC, CPCP. And this allows for 3 months run out for each quarter before determining performance. I think that also gets back to the point that I think Dr. Pham made a minute ago, that the reporting on this is difficult. To make decisions on data that's sometimes a year old, when we're doing these quality measures, is very difficult. So the data has got to be more real time, which is a problem with every system we've had so far. And the final thing on that is providers that exceed the total cost of care will have their PBP reduced by 10% the quarter after performance is calculated, and reduction will be eliminated to 5% if the practice meets or exceeds the quality gateway. So,
and Dr. Reedman, Dr. Pham has a question.
Yes, go ahead.
Oh, I'm sorry. I thought you were done, Dr. Reed.
No, I am. Go ahead. I've read through those.
I'm a little surprised that we have more confidence that CMS is going to be able to generate reliable estimates of total cost of care at the practice level. They removed that from primary care first for a reason. And so I'm just surprised that we're going there. Theoretically, I think directionally, it makes a ton of sense. I'm just not sure how the agency is going to react to that. So that was the point. And so because of that, I'm a little skittish about punishing practices if they, quote unquote, seem to exceed total cost of care. There would just have to be, really significant uncertainty bands around that. Just so that there are no sort of arbitrary and nasty surprises.
Okay.
Yeah, this is Patrick Dooley. So I would tend to agree. I mean, I think one of the things that gave me the most heartburn in just reading through all of this is just holding the primary care practices to a total cost of care metric, particularly with the small number of attributed lives that ultimately some of these practices could have. I mean, there's a reason, MSSP has a 5,000 beneficiary limit. There's a reason why other programs out there, PCMH or otherwise, aggregate larger panels to measure performance. So I just tend to agree, if total cost of care is going to be measured at the primary care practice level, I think we need to be very careful about how it's measured and what either the rewards or consequences are that are associated with it, just given the, at least in the current proposal that's reflected, small number of beneficiaries and what just a few could kind of do to give a bad bounce to your overall total cost of care year over year.
And I apologize. Can I just add quickly? This is a place where I'm going to bring this up because I'm not sure that we're going to be talking about pricing anywhere else. But total cost of care, savings or losses relative to what? This is all about COVID for the next some number of years. Either CMS makes a blanket decision that when they look at historical data, they're only going to look at pre-COVID history, or they need to demonstrate to us that there is, we need to have an opportunity to opine and provide feedback on some other methodology that they come up with. They have not convincingly explained how they will do any of this. If for ACOs, they are simply excluding all the months affected by the public health emergency, which is to date about, 10 months out of the year. And amortizing the losses or savings, it's just the losses based on that calculation. That's not a sustainable methodology. I think we need to call out the question to the agency. All our recommendations are premised on the assumption of ... Because I'm very worried that, there's going to be some unpredicted tilt of the winds at the agency, and we're going to end up regretting not having called the question.
Dr. Haft, your reaction?
Yeah, no, I agree. I think we need to call the question, and it should be part of the lens that that the proposal is looked at. But I will be not shocking to anyone. I have at least 4 significant objections to total cost of care and primary care. One is small numbers, as Dr. Pham has said many times. Another is risk adjustment, and which is not apparent how that would happen. The third is that particularly in Maryland, it makes no sense because the reductions in utilization do not necessarily mean any reduction in cost of care. They can in fact be paradoxically, and have been paradoxically, reductions in utilization have been visited by increases in cost of care. So the work that you do to reduce utilization may actually not be visited in any reduction in cost of care. And fourth, and most important, is why would we want to hold those who have the smallest piece and the least leverage in the entire healthcare delivery system responsible for the total cost of care? That on its surface makes absolutely no sense. So other than those objections, I'll stop there.
Dr. Berenson.
Well, I associate myself with Dr. Haft's all of his remarks and agree with them. The question I had in the recommendation to not to reduce or eliminate acute hospital utilization as a metric, I didn't see any reference to the fact that there are well-developed schemes for ambulatory care sensitive conditions, not just all hospital utilization, but specific conditions that are affected by primary care practice. Why wouldn't we be interested in that subset of ambulatory care sensitive? Dr. Haft's talking about the hospitals and budgets anyway, and why would we necessarily care about utilization? That's an interesting point, but I do think to keep people out of the hospital is a quality thing also if they don't need to be there. So I guess my question is whether we are talking about just acute care hospital utilization or some subset related to ambulatory care sensitive conditions, and whether CMMI has that concept in some of their work.
I think that's it. I think that's in here that we're wanted to focus on the PQIs, both ED and hospital PQIs, rather than total hospitalization.
So I'm sorry, what's in here?
The ambulatory sensitive conditions.
Oh, okay. Because I thought there was a consensus to eliminate AHU. It says number 1.
I think it was the consensus was about overall hospitalization, just to focus on the segment of that are ambulatory sensitive.
Oh, okay. I missed that. Thanks. That's great.
Okay, and Alana, we want to make note, please, as you're going through there, the comment Dr. Haft made, so it clarifies the point. Okay, Dr. Riedman, any other comments here?
No, I agree with the total cost of care. I think everybody's comments were right on from that standpoint, and I think the consensus is pretty good on that. It sounds like so. If there's no other questions on that, the next 2 items, we want to go to the attribution of beneficiaries real quick, because there really wasn't a lot of comment on those.
Okay, yeah. So Dr. Riedman, I think you're suggesting we can skip the attribution and beneficiary engagement items.
I would, unless somebody has a comment on those. Okay.
Okay, good enough. So we're now moving on to, if you want to scroll down, Alana, to the performance measures, and we're looking at risk groups 1 and 2. These measures include patient experience of care survey, controlling high blood pressure, diabetes, cholesterol, colorectal, cancer screening, and advanced care planning. It also talks about utilization measure for PBA calculation in acute hospital utilization, and discusses the quality gateway, which would begin in year 2. So the consensus in the recommendation in this area was to simplify quality measure reporting and align with state population improvement goals, start quality in year 1, and simplify the gateway, and the quality must be hit to retain the bonus. And Dr. Riedman, to the consensus.
So I'm going to take this opportunity to tell a brief story because I wanted to tell this before our last meeting, didn't get a chance. But and I don't have an answer to this. I'm just asking for everyone to keep this story in mind as we go through this. But I had a patient that kind of drove this home sometime in February. He's a man in his 74-year-old who's got metastatic pancreatic cancer. He's terminal, got diabetes and some other health issues. And I saw him in the office for his annual wellness visit back in February. And when I started the visit, he said, Dr. Raymond, I know you're a busy guy, but you have 5 minutes to look at something for me. And I actually thought he was going to show me something on alternative therapy or something. But what it was is he doesn't have a lot of financial means. He's from Holland. He moved from there when he was 20 years old. But his family and his friends pitched in to get him a trip to Holland to go down to meet some cousins he had never seen and take a barge trip. So what he pulled out of his backpack was this beautifully done photo book of his trip down the canal. And we ended up spending about 15 minutes on it, not 5 minutes on it. And he told me all the stories of where he went, what he did. And it was a wonderful experience. But at the end of it, he said to me, Dr. Raymond, I really appreciate that. It meant a lot to me. And I looked at him and said, it meant as much to me. It's not, as it did to you. I think that the day I came to that is the day I quit medicine. What I realized was also when I walked out of that room, never got a chance to ask him about his annual wellness visit questions about whether he was depressed and whether he had stairs in his house, et cetera, and et cetera. And I didn't ask him the 9 questions about depression that we're supposed to ask because the guy's got terminal cancer. His A1C turns out was 8.4, 74-year-old with terminal cancer. Well, that's a quality measure I didn't meet. The blood pressure that day was 155, so I didn't meet that quality measure. So in my mind, that's the guy that's going to call me back about before he goes to the ER. He's the one that's going to call me about the specialist puts him on X medications. He's going to call me before he goes on it. He's going to see me before he goes to the walk-in centers, et cetera. But that, from a quality standpoint, I did nothing right. I got no credit for the annual wellness visits. I got no credit for his diabetes, no credit for his blood pressure. And we have thousands of cases like that all the time. So I don't know. I'm not smart enough, and I don't understand all the. You guys understand the statistics behind all this and all, and it's not as easy to say, well, how do you measure that? That's difficult. I think you measure it somewhat because of the ED visits and hospital outcomes. But I would just ask that as we go through quality measures, that you keep that in mind about if anybody has a suggestion of how to measure that quality. I think that's really important. I think that story says a lot about how we're measuring quality. Dr. Sam, you had a question?
Well, no, I had the suggestion you asked for. I'm just looking at Dr. Barr, whether he thinks this is where an instrument like Elizabeth Eby's survey could be useful. If we could at least draw CMS's attention to it.
Dr. Barr? And you're muted for some reason.
Double muted. That's the risk of muting on the computer and on the device. Dr. Raymond, I don't know if you saw my comment. I wrote, you did everything right.
Thank you.
In that visit. And I think what Maya's talking about is sort of a person-driven outcomes, sort of getting person-specific stuff. Doesn't have to be all about the kinds of measures you were citing. So I think this is an opportunity. I may have mentioned this in some of our earlier conversations about, complex patients with multiple comorbidities, what's meaningful for them, what matters to them, and making that part of the measure. As an accountability measure, it's probably not ready, but as an engagement strategy, as an improvement strategy, as in doing the right things and getting credit for it, if we go that route, I think that's the right conversation to have.
Yeah, I think we would agree. With Dr. Berenson, were you trying to make a comment? Yes.
Yeah, I guess this is I don't have the background. Are we doing pediatricians here too, kids? I mean, are they primary care docs? These measures don't apply to them.
Dr. Haft?
We're not.
So there's the commercial aligned programs. Care First is our partner in an aligned program, and they do pediatrics, and they have a separate set of and Stacia can opine to this better, but they have a separate set of quality metrics that pediatrics.
Right.
My other comment is much more general. I think I wrote the word stale. I think just having a handful of largely processed measures and self-reported blood pressure it seemed to be relevant in 1995 to use 140/90. I just read the most recent article on hypertension from May of last year, and the standard now is 130/80. And there's a lot of literature suggesting lower is better. The Million Hearts project there's a number of initiatives in that could be adopted about self-monitoring of blood pressures. So I just think that we could do better. I don't think we have to do better for year one, but I think that we could do a lot better than these measures. And they, in particular, well, okay, that's all I would say. It would take some work, but I don't think these really are a robust set of quality metrics. They mostly reflect to a few fairly straightforward prevention metrics and don't really give a measure of quality.
So,
Dr. Reedman's comment about his care, it's not reflected here at all.
So, Dr. Reedman, are you comfortable that we would go with the consensus, but here again, we'd add some narrative around the points that are made by the advisory committee here?
Yeah, I think so. The problem with this is it's great to say that that's a quality visit, and I consider that, and I consider that's why I do medicine. But how do you measure that? And is CMS going to go for, as we mentioned before, about some changes? You know, it's great for us to theorize this and have a conversation, but when we make a practical recommendation to CMS, what are they going to say if we don't have any specifics? I had a great director for my residency program, and where I was chief resident, and every time I walked in his office, he had a sign behind his door that said, if you're not part of the solution, you're part of the problem. And he subconsciously looked at that every time. So I think that, yeah, I agree that if there's an alternative, I'd love to see it and consider it as a recommendation, but I think it's also got to be practical that CMS would consider it. And some of the surveys you're talking about, I'd love to see that. I've never seen those before, but if we could make that as a recommendation, I think that'd be great.
Okay.
My point is it would take a lot of work, so I don't have it out of my back pocket right now, but I'm just looking at that hypertension article and the Million Hearts. One could develop a few metrics rather than just have a few scattershot measures, maybe take on a few high impact conditions and really have a set of them, but nobody has really solved the problem of what we're measuring. I'm pretty pessimistic that we're measuring anything that really matters.
Right. But Dr. Berenson, I think we all have that after many years of measurement without significant improvement in the population, healthy population, we'll have a healthy skepticism about that. To align it with the state, what we hope to do is to be able to say that at the state level, we will at least pick a few top box measures that we're really interested in aligning not just this program, but all the interests in the state. So we picked, like for the first year, diabetes, the reduction of diabetes incidence, so pre-diabetes and pre-diabetes. We have in the state health improvement plan things like reducing opioid deaths, which are meaningful. So it would be trying to match up a measure that would align with that. There could be other measures also, but I think what we hope to do is have kind of this as part of an aligned. The measures that we're striking at should be aligned with what the whole state is doing to develop kind of synergy along those lines. Doesn't mean there couldn't be other measures, and it certainly doesn't mean that the patient-based measures are not really the most important ones. ABFM has put together a series of kind of 11 questions that they validated with CMS to some degree. But I think those are great points, really great.
So any other comments onto this particular risk group 1 and 2? Okay.
David, it's Michael.
Michael has a.
Michael, my apologies.
It may sound odd coming from me at NCQA in terms of measures, but I agree wholeheartedly with Bob in terms of these aren't the measures I'd love to see. And many of them are NCQAs. I'd love to see Maryland be more creative and innovative, but I'm trying to understand sort of that balance that you started out with in terms of what would pass muster through CMMI and CMS versus what time do we have to be creative and look at some of the new ideas that are percolating up with digital measures, use of data in different ways, the patient reported or person-driven outcomes measures, a new opportunity to rethink CAPS, which I put in the wrong box in my comments because it's the next one. But anyway, that's kind of where the guidance from the state is really important, because I'd love to see this be more creative and innovative too.
Yeah, so Michael,
At the clinician level, it brings risk. It's new measures they're not familiar with. And so if you're putting payment at risk as opposed to on performance, there's that other dynamic too.
Dr. Half and Dr.
yeah,
Pfaff.
so just to level set, this is one place that we are granted more flexibility in terms of selection of measures. That was already built into the kind of the total cost of care contract. That there would be alignment of the state's population health measures. So I think here we might get more flexibility than any other place. So think in an innovative way here.
Would it be possible to experiment? So not to displace the current measurement rubric, but alongside it, collect data on, you know, 1 or 2 additional measures that might replace them in the future that we think are worth investigating, and have Maryland be CMS's pilot of that. It's not an awful lot to ask of the agency, and it's lower risk for them than trying something experimental, you know, in their ACO programs or in primary care first.
Right.
If you feel, if this group and the Maryland team feel strongly about wanting to go in some innovative direction, then I say innovate, and you can do it in a way that does not put the program at risk.
Yeah, very good point. Dr. Berenson.
Yeah, my point is going to be that, again, figuring what CMS might want us to be doing, unless I'm outdated, which is possible, MACRA set up of the various MIPS measures, they were going to include up to, I think, 25% of the score would be based on quality improvement projects. And then that got postponed like for 5 years or something like that. I see a real opportunity for us to pioneer actually, how do you, with small practices, develop practical, useful quality improvement projects rather than just measures. And so I throw that out. I would, you know, in this whole area of quality measurement or improvement, I think there would need to be some dedicated time and work to try to come up with some reasonable stuff. And I, for one, would be happy to volunteer to help do that. But I don't think it's going to be just a layup. I think it would take a fair amount of development time. But I'm specifically suggesting that maybe quality improvement would be something we would take on.
So why don't we add a lot of pioneer quality improvement concepts, and that can be, I think, for in the recommendation back can be some narrative or discussion around feedback that can be shared with CMMI.
This is Stacia. Might it be worth perusing the more than 700 endorsed NQF measures that are out there already to see if there are some that might feel like they're a better fit? Because I think coming up with a completely new measurement, then we also have to think about how do we get measure endorsement. And not that we can't do that, but I'm just wondering if there's already more than 700 endorsed measures, if there's some out there that have already gone through sort of the rigor of measurement analysis to see if if they can be endorsed measures.
I think Dr. Berenson, you appear like you want to make a comment.
No, I was going to just say that I would have hoped that CMMI would have picked the cream of the crop for primary care first, but I think you might be right that maybe they just took some convenient things off the shelf. I mean, this is pretty puny in terms of a measure set for what I think will become a very important payment model.
I don't think that CMS leadership at the time was focused on quality, Bob.
Well, there you go. No, so I think that's right, and maybe that we could identify some other NQF measures that just feel better to us. I would say not to replace, but to maybe supplement what we've got here. What we've got here, I would say, somewhere I read that the more weight should be given to the quality performance and the utilization performance. I wouldn't do that, given how sort of limited this quality set is. I would certainly not overweight the quality measures. If we can come up with some additional ones, then yeah, then maybe.
Yeah, I think Dr. Wiedner weighed in via text, and he agrees with Dr. Behrens's point. Melanie, was that accurate, or did I miss something?
Yeah, so Dr. Wiedner said that he actually agreed that reviewing NQF measures would be a good start. So I think he was agreeing with Stasia as well. So
yeah,
I think we could have an easier time getting it through CMS if it was already an endorsed measure. So when I think about, the various hurdles we have to clear, that might lower the bar on that barrier.
Yeah, I think that's right. I mean, if we sort of go with NQF measures that are a little more robust than these, but then pioneer quality improvement, I think we've got a good mix. We've got a good package to propose.
Yes.
So,
this is Patrick. Just one quick comment. I like the idea of looking at the different measures. The only thing I would say is let's just be aware of kind of have those measures been tested successfully in other places, because I know, with the first year of the primary care program, a measure was picked, which just wasn't necessarily operational. And so, just one thing to consider, but I like the idea of trying to look through there and see if there are others that fit better.
So Howard,
that was my fault. I'll take full credit for picking that measure. We'll do that again.
So Howard, what do you think the chances of us making this recommendation and getting positive feedback from CMS is?
Honestly, I don't think that's going to be the stumbling block. If our measures are more or less aligned with the state, we're really in an annual mode of changing the measures anyway. So wherever we start with the measures, it's gonna change. So I don't think we should. I think we'll have time to build on them. So we pick an acceptable set to begin with maybe something experimental a bit, and then build on it year over year. We'll have time to change that as a program evolves. So we've given flexibility there.
Okay, and Dr. Pham, I'm not able to see you. Were you any more remarks you wanted to make? Okay.
Sorry, having trouble coming off mute. No, I mean, I completely agree. We should experiment. Yes, in all practicality, being NQF endorsed will make it a little bit easier. Although I will note that, CMS specifically wrote the macro reg to not require NQF endorsement, and that was for a reason, and that is a long-term trend at the agency.
That's a good point.
So I wouldn't want us to be completely limited by that, but if all else being equal and we've got one version that's NQF endorsed and one that's not, then for sure.
Good point. Dr. Reed?
Yeah, so we've got about 10 minutes to finish up. I'd like to at least get through the performance measure if we can. I think we discussed it pretty well. And then by the way, these first couple of 3 items that we're getting through, 2 of them today are certainly, I think, the most controversial or the most difficult. And then I think our next one will go a little bit faster. But I don't know if I can read through those measures there that to consider the alternatives and to the caps and the simplified measures. But I think y'all can read that. And I think we've discussed it already, so I'm not sure that we need to go through that in any more detail unless someone has some more comments specifically. And the final one was the all risk groups have the same measure under the risk group 3 and 4. So I don't know if there's any more comments on any of that.
I think Dr. Barr wanted us to make sure that his comment gets noted in this area. That Dr. Barr, I think you said it was placed under risk groups 1 and 2, and you wanted it here to make sure it was noted under 3 and 4.
I think it was related to the caps. I think I may have put it in the wrong place. Just if possible, consider an alternative to caps. Nobody seems to be happy with it, but nobody wants to do anything about it. So here's an option.
Okay, good enough. So then are we headed into general options if we scroll down? So that's line item 7. And I think you see that on your screen. So in the interest of time, where this area talks about practice capability to deliver the 5 advanced primary care functions, I would assert, Dr. Riedman, for consideration that there was no concerns or on alignment, so that we could move on. But the general discussion item here is around the seriously ill population, and is that a 5 tier? A 5th tier, I think that's the discussion item. I yield to you, Dr. Reedman, on that.
Yeah, so the suggestion was to keep tier 5 and not to adopt the seriously ill patient measure. So I'm looking for feedback from anybody on the committee about how they feel about that. So any comments? Stacey's holding up. He's taking, I think he's looking through it.
Stacia, you're on mute, self-mute.
I am on mute, sorry. Sorry, I was sneezing and I couldn't hear.
Were you making a point to Dr. Reedman's question?
I think she was just shuffling some papers, and I just saw the. I don't think she was actually asking a question.
Got it.
If I'm wrong, just interrupt me, okay? So,
I
does
was
anybody
just sneezing, sorry.
Okay, that's her. So, does anybody else have any issue with keeping the tier 5 and not adopting the SIP? Bob, you had a question?
Yeah, if I remember right, all of these tiers are associated with HCC scores. Is that right?
Yes.
So this sort of makes my point. I don't think a geriatric practice, for example, a lot of their patients with dementia and lots of family issues and social issues may be reflected in an HCC score. Patients may not be hospitalized. They may not go to a nursing home, to a skilled nursing facility, but they are heavily burdensome for the practice. And it's another reason why I'm all for having a tier 5, but the tier 5 shouldn't be based on HCC, I guess is what I would reiterate.
This is a point of order.
In particular.
I think that's a great point. As a point of order, if we adopt what we just move forward, the risk tiers that we have currently in the program, our complex tier or the 5th tier already reflects that. So anyone with dementia, anyone with SMI, or with a high HCC score would be in that.
Yeah, no, I applauded the fact that they identified a couple of categories. If that's all, I mean, I would just want to make sure that seriously ill people that we haven't missed other categories like dementia. That would not be reflected in an HCC score. I like the idea of actually labeling some conditions. And I'm just not off the top. I don't know what other conditions I would consider, but I think that's the right approach.
And Melanie, did Dr. Wiedner have a comment to Dr. Berenson's point?
No, I'm sorry. Yes, so Dr. Wiedner says keeping tier 5, keeping those dementia in tier 5 as they are now, but let's add tier 5, a complex social patients who have high SDOH scores as well. Those are the most difficult patients with multiple barriers to care.
Okay. So that works well in the notes. So Dr. Reedman, we have 3 minutes left on the clock. Okay to wrap this up and sort of highlight where we're going?
Yeah, I think we should be able to get the rest of it in 3 minutes if that's okay with everybody. If not, we'll wait and save it for our next meeting. So no, I'm actually fine. I think I tell you this was an excellent conversation. I didn't know how far we would get tonight, but I think the comments were right on. I think everybody has excellent feedback. I really appreciate it. I think I told everybody the first meeting way back that this would be fun, something I wanted to do, or worthwhile. I think it's turning out to be most of those. It's been more informative. I think it is worthwhile. I think we're accomplishing a lot. We have a very tight time frame, as everyone knows, because of the COVID issue. CMS did not push back our deadline, although the rest of the world was pushed back from the timeline. So I really appreciate everyone taking the time, giving us the feedback they have, and I look forward to next Tuesday's meeting. I hope we get through the rest of this template by next Tuesday's meeting if we can, which would give us our 3rd meeting to kind of summarize things before our final committee meeting. And I don't know if David or Howard have any final comments either.
So thank you, Dr. Reedman. We are almost halfway through the template, so it's possible that we can get through it at the next meeting. We have comments in areas for consideration under total monthly payment, under performance based adjustment, and then we have some under the risk groups and general options. So not so bad, but we'll work through those as well. Before we scoot, I want ask Dr. Haft if he has any comments, and Ben, our executive director, who is usually has thoughts to share as well.
I don't have any additional comments, so thank everybody for your wonderful contributions. This was remarkably productive for an hour and a half. I'm just absolutely amazed. Not really amazed because of people, just amazed because of the context. The video conference to do this much in this short a time is pretty significant. Thank you, David, for leading us. Can't do it without your leadership.
Thank you, sir. And then Ben, and then Mel.
Well, I really don't have anything more. I think that coming back and revisiting those areas where there's some questions is really important. I think that our state collaborators at HSCRC are going to particularly be interested in the areas of where we have issues yet to resolve. So I want to pay attention to that. But I really appreciate everyone's hour and a half contribution today, and look forward to further progress next week. Hopefully we continue all to stay safe, and the blip today we saw in cases was just a blip, and we come back to the steady downslide in COVID-19.
Yeah, agreed. Melanie, operationally,
just some very high level final items. So the Google Sheet will be serving as the record to show the detail of what we discussed during these committee meetings. We will be sending out a very high level meeting summary that's more like a bullet point format. And as Dr. Riedman mentioned, we are having a meeting next Tuesday from 5 to 6:30, the same time frame. So everyone should receive a Google invite who's on the committee. So it'll be the same thing. When you get the Google invite, you can log in and be on the video and be heard. To the public, we'll be releasing a phone number. So I think that's it, David, unless there's other items.
Dr. We will try to connect with you offline to see if we can help you with the technical challenges. And then Patrick, if there are some challenges that we can help you with, please let us know. And with that, Dr. Riedman, if there's no other points, I will say goodbye to everyone. Have a great evening, and thanks again for all your hard work this evening.
And
Thank you.
Bye.
Bye now.
See ya.